Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Kevin. How are you doing this morning?
I'm doing great, Dennis. How are you?
I'm doing well. Today I'd like to talk about, waking a patient up. Like you've sedated them, and now it's time for them to wake up and put their shirt on and go back to work, right? I know it's not necessarily as easy as that, but since you are a CRNA, I figured you'd probably be the guy to talk to about that.
Yeah, of course. So I think the first scenario that you wanted to talk about was if we're going to do some procedural sedation. Typically, most of the folks that listen to this podcast are probably going to use some sort of ketamine, maybe some Versed, maybe some fentanyl, and say you're putting in a chest tube. So where chest tube is in, you've given however many, whatever your dose of ketamine or whatever your dose of Versed was, and everything's gone well. There's a few things I typically do before I bring a patient back that maybe already has PTSD, or I feel like they need to have a very quiet environment when they wake up, especially at WOMAC. So typically I'll plant some words or some sayings. Usually I'll tell them, I'll be like, "Hey, Dennis, so we're gonna give you some ketamine. We're gonna give you some sedation medicine, and then when you're waking up, you're going to hear my voice, and I'm going to reorient you to where you are and what's going on." So like, "Hey, Dennis, we're in country wherever, you're safe, just waking up, just put a chest tube in, everything is fine." And that's what I'm going to say to you over and over again until you kind of recognize where you're at and that you're back, is kind of what I say to them. And I find that works pretty well. Most of the time, sometimes it doesn't work, but I try to plant those words before I start giving them medicine, so that way they can hear my voice, and I'm just trying to reorient them when they're waking up. So that's kind of that's the prep portion of this.
Sure. How can you recognize that they've woken up enough that they're actually oriented? You want them to talk back, or?
Yeah, I mean, I ask them. I'll be like, "Hey, Dennis, are you back? Like, are you with it right now?" And some people will say yes, yep, I'm back. Yeah, this is where I'm at. This is what you guys just did. But I've seen, especially with ketamine, I've seen people kind of go in and out of coming back, and then they kind of go back into maybe being a little disinhibited, and then they come back to being oriented. So that's typically, you just have to keep an eye on them and just, "Hey man, you back? Like, you good?" And then like they'll say yes, and I'm like, "Hey, where are you at?" And they'll tell you. You can ask just some some questions just so you know if they're oriented. But I've seen it kind of on a continuum, kind of go back and forth. So I just continue to monitor them, continue to just make sure that they're doing okay. And then, so like with sedation, I mean, typically we just turn the sedation off, and then we just with time, that medicine will decrease in the bloodstream, the clinical effects subside. But with ketamine, you can see some emergence delirium, depending upon how bad it is. Sometimes I've seen people just are kind of like, "Hey, where's my weapon? Where's that?" And I was, "Hey, all your sensitive items are secure. They're good." And I just kind of keep answering those questions over and over again until they kind of recognize that the clinical effects of the medicine have worn off. Maybe that delirium has gone away. Now, if the delirium is severe and they're a danger to themselves, they're trying to pull out their chest tube, or they're trying to get up and run, you're going to have to act. Like, so you kind of have, if you have midazolam, that would be a good time to use that. And you don't have to give a lot, like typically like maybe 1-2 milligrams, start there, and then just kind of see if that helps with the delirium. Because all you're trying to do is get the Versed to outlast the ketamine that they're coming off of. So you don't have to give a lot of it. And typically I've seen that works pretty well. But really, you're just trying to keep them safe. You're trying to reorient them when you're coming out of sedation, and it's typically a little bit it's easier to do that when versus emerging from a general anesthetic. So and then you're just like, airway, breathing, circulation, making sure their vital signs are all they're stable. Whatever intervention you did, obviously you're monitoring that. But for the most part, sedation, you just stop giving the medicine, and I mean, if you don't have an advanced airway in, so they're not going to have that stimulus and be coughing and trying to get it out. They're just kind of going to emerge and wake up. And then they're either going to be oriented or not. They're either going to be some sort of we call it a stormy wake up or a combative wake up. And if they have a combative wake up, you just have to make some decisions on how you're going to deal with that. So if you have 20 other patients that you need to take care of, you might want to medicinally deal with that. If this is your only patient, then you can just talk to them and just try to reorient them, try to calm them down. And if that doesn't work, then yeah, you're going to have to go the medicinal route until that disinhibition stage is over. So that's pretty straightforward for the procedural sedation portion of it. And then obviously just being prepared to, if you have to take an airway, that's a given. Like you're ready to re-induce, put a ET tube in if you need to. So, and then I'm sorry, go ahead.
Because if you just look at indications, right, for an airway, loss of consciousness, generally, at least I found that, if I'm doing a procedure, more than likely it's not going to be in the OR or hospital or somewhere comfortable. So usually it's somewhere very uncomfortable. So like, I have no idea. Did this guy, he probably ate not too long before. There's so many unknowns to this, mm-hmm. right? And if you, like I said, if you look at just the indications, loss of consciousness, is he going to vomit? Because we're not only from the pain, but now we've given him narcotics on top of that. I guess, what's your opinion on, like, when do I take this guy's airway? Because once you take his airway, now you bought even more work.
Yeah, that's a challenge, especially in the downrange environment. So yeah, so whenever you're doing a sedation on somebody that's a trauma patient, I mean, you're assuming they're a full stomach, right? So the emergency medicine folks have this dilemma all the time down in the ER. If they have to reduce a fracture, and they don't want to bring them to the OR to do it, they have to assume that risk. Now, typically when you're doing a sedation, kind of by definition, those airway reflexes are still intact. So even though there's a loss of consciousness, they're supposed to be ventilating, they're supposed to have airway reflexes. So if they did vomit, that they're going to cough versus just passively aspirate. Now, I'll tell you, that is very challenging when you're trying to sedate somebody and you're like, okay, I have to keep them still, I have to keep them ventilating, I have to keep their airway reflexes intact, but they also have to tolerate whatever procedure you're trying to do to them. So, I mean, typically ketamine's a great drug for that, because you'll keep them spontaneously ventilating, their airway reflexes should be intact, and then, but at the same time, you absolutely have to be prepared if they do start to vomit. Like what is your plan for that? I think we all know that the field suction devices out there aren't the greatest. Can you delay the procedure? Are you talking to them like, hey man, when was the last time you ate? If they're not verbal, then you've got other issues. So those are some questions you can ask, but I think it's a risk. It's a risk you just have to say, like, all right, I'm going to assume the risk of doing a sedation on somebody for a chest tube, even though they ate, 4 hours ago and they just slammed 6 Rippets before they went out. So yeah, like you're just going to have to assume that risk. And then, depending upon how soon after they ate, like, you might tell them like, hey, like, this isn't going to feel good. We got to make sure those airway reflexes are intact. So the continuum of anesthesia, like I definitely, I can do a general anesthetic on you, but that's just something I don't want to get into. I can try to do this while you're wide awake without sedation, just using local. I think that's still not going to be adequate. So doing a chest tube, if you have local anesthetic, plus maybe the analgesic dose of ketamine with maybe a milligram of Versed, you can get away with doing it with the minimal amount of medicine needed, and go from there.
Yeah. Just out of curiosity, what does your airway kit look like? Normal, what I see is a tube, a scalpel, and some IV tubing cut down.
Yeah. So so for in a deployed environment, really, I just have an ET tube, a laryngoscope blade, and a bougie, and then a Cric kit. So that's kind of my airway kit. So in a
Do you
hospital,
bring
obviously,
suction with you?
yeah, I mean, wherever I'm at, that's the one thing that you can't reproduce. Like you can reproduce mouth to mouth, like you can reproduce a lot of other things. You can't reproduce suction. So I always I have some sort of suction device available, whether it's the squid or if I'm in a higher level of care, like actual suction. So I always try to make sure that I have that for sure. And it's available. It's kind of sitting. I usually, when I'm doing this in a deployed environment, like if all I have is my squid, that squid is sitting at the head. Like, so I don't have to go digging out of my bag trying to find it while somebody's actively vomiting. So
People forget how fast somebody can aspirate when they're breathing, 40 times a minute or.
yeah, I mean, it's so we always teach our CRNA students kind of like a drill, right? Like, what are you going to do when this happens? And it happens, right? Like, people have full stomachs and you have to do an emergency procedure and you're doing a rapid sequence induction and intubation. And sometimes you push those medicines and, even if you have cricoid pressure or don't have cricoid pressure, you go to place that airway, you open up the mouth and it's just filled with vomit. And you're just like, okay, here, it's my life right now. And you just have to deal with it. So typically you're trying to suction as much of the stuff out of the oral pharynx and the back of the oral pharynx as you can. And then you're going to put a ET tube in. And then prior to positive pressure ventilation, you should, if you have a longer suction catheter, try to put that longer suction catheter down the ET tube, suck out as much as you can if anything went into the lungs, and then ventilate. You always want to try to suction the ET tube prior to positive pressure ventilation, and you're just pushing whatever vomit has reached. Maybe it's not quite into the bronchial main stems. Like maybe it's still just sitting down by the carina. You can try to get some of that out before you use positive pressure ventilation.
So another thing, especially for the long course graduates, like we have some, I guess, relatively simple surgical procedures like debridements, amputations, things like that. Unfortunately, we don't really practice it that much. And realistically, every 2 to 4 years, we get some actual practice where it's our decision and we get to do the whole thing versus I get to hold it for an somebody actual else. Surgeon. Yeah. So the procedures, they go quite a bit of time, like hour plus.
Yeah.
Right. And I think in a real world, you're probably not going to have just one patient where you end up having to do a procedure like this. If it comes down to me, there's probably a bunch of them stacked up outside that need some kind of intervention on. So, which leads to longer down times. Somebody's at the head monitoring it very closely. Somebody who actually knows what they're doing. As far as my narcotics and my monitoring the airway and et cetera, it just all takes time. When you have somebody down for a long time, like when you're in the OR, like how do you start, like when do you start and how do you start waking them up?
Yeah. So I can speak to a case I had. This was actually an elderly lady who needed a gastrectomy, and I was using all my deployed equipment, and I did my Tiva mixture of the ketamine Versed in a 250 bag on a mini dripper. In this case, I think went close to 8 hours, and I think when I looked at how much ketamine she had in that 8 hour time period, it was probably upwards of about a gram of ketamine and probably close to 35, 40 milligrams, maybe not that much, maybe like 30 milligrams of Versed over the course of 8 hours. And then intermittent bumps of fentanyl and Dilaudid during the case. So the place where we were at, there was no ventilator, there was no oxygen. I was going to hand this person off to a recovery room that had one RN or one nurse, and then probably had 50 or 60 patients. So I really had to make sure that this person was able to tolerate going to that environment. So this is obviously a super long case, lots of ketamine, lots of Versed. So really, at the end of the case, so like in general, when we're getting ready to emerge a patient, I'm always watching to see what the surgeon's doing towards the end of the case, and it's always communication, like, hey, how much time do you think you have left? And then you're looking at the sutures they're using. I'll even get to the point where I will, depending upon who's closing, how many seconds per suture, and then I look at the length of the incision, or how many incisions they have to close, and then I'm just kind of timing my wake up based off of that. So when you're doing a Tivas are a lot harder to emerge than like when we're using a gas, like whether it's isoflurane or sevoflurane. It's just more challenging. So we're getting towards the end of the case, and typically, if the patient has not been ventilating on their own, if the ventilator's been doing all the work for them, you have to get them ventilating on their own. So, and then if you've used a neuromuscular blocker on induction to put the ET tube in, you have to make sure that neuromuscular blocker is completely reversed. So, like in the OR, we typically use like a twitch monitor looking at a train of 4. If you don't have that downrange, like that's a challenge to kind of see whether or not they're fully reversed. So there's things that we can look for. You can ask the patient to, while still intubated, which is challenging, is like, and they have to be able to communicate with you. Like they talk about lifting the head up off of the bed for 5 seconds. It's called the 5-second head lift test. You can ask them to squeeze as hard as you can on your hands, but these, like the head lift test is more objective, but just squeezing, like asking them to squeeze your hands, that's obviously a lot more subjective. So you're without some way to tell whether or not they're fully reversed, or at least well enough to extubate. Like you're looking at tidal volumes, and you're looking at their respiratory rate and things like that. But the layman's term that we're trying to avoid is extubating somebody and they're still weak from a neuromuscular blocker and they kind of look like a floppy fish. Those patients are probably going to go into respiratory failure if you don't have any way to reverse them, and you're going to probably have to wind up re-intubating them. So you want to try to avoid that. So back to your original question is, so I would say, like, if you're doing a fasciotomy, and there's really there's no sutures to close, I would say because you're going to be doing the procedure, you're probably also running the anesthetic as well. So let's say you intubated them, let's say you didn't use any type of neuromuscular blocker, and you're getting towards the end of the procedure, and you're putting the bandage on, like I would say, like definitely turning off if you're doing a Tiva on a mini dripper, I would probably, especially with ketamine and Versed, I would probably turn that off the second you make your last incision, and then just turn it off. And now you're putting the dressings on, you're doing those things, and at the same time when you're doing that, typically, what I would do is, depending upon what the ventilator was, but I'm always trying to save battery life downrange. So I would just turn the ventilator off and just disconnect it and leave my EMA on the end of the ET tube, just so I can keep an eye on them ventilating. You do lose some information, like you have no idea what their tidal volumes are. Your end tidal CO2 might not be actually accurate just because you're mixing it with atmospheric gas, but it's you can look at them. You're looking for respiratory excursion, and you're looking at, like, you can see the end tidal CO2 waveform maybe, and you're just making sure that they're not apneic. And then the other thing is I keep the pulse ox on them, and I'm just watching the pulse ox. So with this elderly lady, what I had to do with her was I did that. I turned the ventilator off. I put had the pulse ox on her, and I had an EMA, and she was ventilating, but then her sats would continue to drop, and I just kind of keep an eye on them. And then her sats got down, and it's probably like 90, 89, and I was like, okay, let me fix this. So then I would just hook her up to an ambu bag. I would ventilate for her. And I would ventilate with her, but I would just give her bigger tidal volumes. And then I would get her sats back up to, 96, 97%. And this is on room air, just 21% oxygen. And then I would just disconnect the ambu bag, and I'd let her ventilate on her own, watching her O2 sats. And then eventually I saw that she was holding her sats probably 92, 93%. Her respiratory rate was, less than 24, greater than 12. She looked okay. And then I would, just talk to her. She would open her eyes. And I would just ask her, are you okay? And she tolerated the ET tube just fine. I think she still had plenty of analgesic on board towards the end of the case, to where she would tolerate that ET tube. And then I looked at her. I was just like, okay, so I know she's fully reversed, right? So she's now following commands, because I asked her to squeeze my hand. I asked her to open her eyes. She was holding her sats. Her end tidal CO2, from what I could tell, wasn't extremely high. And then otherwise, her vital signs were stable. So those are kind of all the things that I look for before I extubate somebody. And then so I chose to extubate her. I immediately went and put an oral airway in her, and she tolerated it. And I think it was just because of the amount of ketamine she probably still had on board. And then I held her in the OR for a little while with that oral airway, and then I eventually took the oral airway out. And she was ventilating just fine. I didn't have to do any airway maneuvers. She wasn't requiring any oxygen, and her respiratory rate and the rest of her cardiovascular status was fine. So then I wheeled her over to the area of the recovery room, and I just kind of looked at the nurse over there, and she just kind of put her in the corner, and I was like, okay. So that's what I did. But I did try to keep her as safe as possible. So when I did deliver her, like, she really didn't need anybody to watch her. So that's kind of that's the one real long TIVA I did with a ketamine, Versed, fentanyl, and then really truly had to extubate this lady to get her off of my OR table and into another area. And just, there was no ventilator that she could use. And if somebody she needed an ambu bag, somebody actually had to sit there and just ventilate her with the ambu bag for however long it took. So these are all things I was trying to avoid.
Yeah. No, so that makes absolute sense.
That kind of answers your question. So TIVAs are tough. Like you're basically just going to turn it off when you're getting close to the end, and then you just have to wait the context sensitive halftime for it to decrease in the bloodstream, so you're no longer getting the clinical effects. And everybody's different, but
I mean, yeah, absolutely, everybody's different. But just for this particular case, how long was it from the time you started turning down the drip or turning off the drip until you put her in the ward there?
It was probably, if I remember correctly, it was about 40 minutes. So it took, and I was overly cautious with her, and I probably could have, So right towards the end of the case, I already had her ventilating on her own. I knew she was fully reversed. She wasn't following commands yet, just simply I think she was still disinhibited or under the clinical effects of ketamine and Versed. If I really needed to send her to the recovery room, I probably could have sent her with the ET tube in place and just her ventilating through the ET tube, and then told the nurse, like, hey, the patient's either going to pull this out or you're going to pull this out, and I prefer if you pulled it out. And a lot of the times, if you guys come spend some time in the OR, that there's a patients wake up, and you're always trying to wait nice, smooth emergence. Like, you just like, hey, Dennis, open your eyes. You open your eyes and you're like, hey, man, you want the ET tube out? And you shake your head and you pull the ET tube out. Super smooth emergence. Everything goes. But then there's the ones where you're like, hey, Dennis, open your eyes. And then you just start coughing. Like, you're basically just the ET tube is just so irritating. And you're trying to and now you're in this weird space. They're not ventilating appropriately. They're not ventilating appropriately because probably it's the ET tube, but you're not 100% sure. So then you're just like, all right, I got to get this stimulating thing out of their airway, or otherwise we're just going to sit here and cough and cough and cough. And you pull the ET tube, and then you're like, okay, what do I have? Right? So are they ventilating? Are they not ventilating? And you just have to kind of pull that trigger and go for it. Now, when I say that, I'm always prepared to deal with the consequences of pulling an ET tube, whether it's a laryngospasm or they're not ventilating appropriately. I'm ready to either treat the laryngospasm or I'm ready to reintubate, and go from there. Those are non-negotiables, at least for me and my students. You're always ready to deal with those things. So you have an ET tube ready to go. You have your laryngoscope blade ready to go, and you've got medicine ready to go to put them back to sleep to deal with the airway.
Yeah. So you have that full mismade kind of stuff ready to go.
Yeah, it's almost, it's so the mismade doesn't stop after induction. The mismade is there all the way through emergence. And you always kind of have that in the back of your head. What am I going to do if I pull this ET tube and they don't ventilate appropriately, or they laryngospasm? What's my plan?
Okay. How much different would be a cric versus an ET tube? Because we don't generally intubate, we cric them.
Yeah, I would say a cric you're probably going to leave in place. I think that I would have to. I know typically, and if a patient gets criced in the hospital and they're no longer requiring that airway, you remove the cric, and then eventually that the cric incision and all that tissue heals on its own. I would have to defer to a surgical colleague of what I would do downrange. I'm assuming I would probably just do the same thing. If you cric somebody to do this, and afterwards there was no indication to keep them intubated anymore, keep that cric in place, do you make the choice to remove the cric and wake them up, or do you make the choice to keep them sedated, leave the cric in place in case you have to continue to go back to the OR? Because I would imagine what you don't want to do is continue to just use that same incision over and over again, pull an ET tube out and then put it back in a day later. I don't know. That's a tough one. I'd have to ask one of my surgeons, hey man, what would you do in this scenario, or what should we do?
Because I would imagine physiologically the procedure itself relatively the same. The procedure of waking somebody up, right? But that cric is really scary.
Yeah, it's probably easier to wake somebody up with a cric. Patients tolerate crics they tolerate them more. They're well tolerated versus an oral ET tube. So I think it would just be a matter of you just like I did with that elderly lady. You just disconnect the ventilator, and eventually they're going to wake up and they're not going to be able to talk. And then you just have to make the decision: are you going to remove that cric, and then just put some gauze over the cric incision? Because
I would think, and I could absolutely be wrong, but what I'm trying to be is as conservative with my narcotics as I possibly can, because probably don't have a giant stockpile of them. But at least from what I understand, like a Cric, like I can use lidocaine and make that at least quasi uncomfortable thing more comfortable. And once they're like coherent enough, they can leave it in. I mean, there's people walking around with trachs all the time, and they're not getting like a continuous infusion of narcotics to keep it in.
Yeah. Yeah, I think it's a challenge, right? Because if you have this Cric in place, I think it's going to be challenging for them to eat or drink, right? Like, so like, and if you're going to hold on to this person for 2 or 3 days in this, or longer in this prolonged field care environment, you're probably going to have to take that. If you think that this is like a one and done, my guess is you're probably going to have to remove that Cric, and then you're just going to have to put a gauze over it, and just obviously it's another wound that you just have to deal with.
Yeah, but I think it's a matter of like I have some time. Like I can call, surgeon friend, and say this is kind of where the patient status is right now. I would like to take this tube out. Like how do I do this properly?
Yeah, and in reality, like in the ICU, as you just deflate the cuff, pull it. I think we put Vaseline gauze over it, just to prevent any, like you want them to ventilate through the nasal passages, oral passages, not so much through the stoma.
Now, when you mentioned getting them off the vent, so the way at least I've done it before is essentially I let their end tidal start climbing till 50s. Like I try to keep it below 60, and then I'm just like doggedly watching SpO2, and that, at least in my head, that CO2 is triggering them to start breathing. Have I been screwing it up all this time, or did I read it right?
No. We do the same thing. Like you're eventually you're letting their end tidals, or their PaCO2 rise to a point where they hit the apneic threshold. And depending upon how much narcotic you've given them, the higher the load of narcotic, the higher that end tidal CO2 is going to be in order for them to reach that apneic threshold and start triggering their own intrinsic breaths. So, but yeah, I mean, like the way they extubate people in the ICU is sometimes they just do like a T-piece trial, right? It's just a T-piece at the end of a ET tube with some O2 blow by in it, and they just they can draw blood gas like an hour later and just kind of see what their PaCO2 is, and as long as it's not rising below 50, below 60, like whatever you choose. But typically if as long as it's not continuing going up, like eventually they're going to reach a minute ventilation that controls their CO2. So as long as they continue to control their CO2, then that tells me that they're ventilating okay. As long as, they're not, ventilating 30, 40 times a minute with these shallow respirations. Typically that's kind of what I'm looking for, is at least the other kind of thing you can do is during the case, if you see what their minute ventilation is and you're controlling their ventilation. So let's say their minute ventilation is 5-6 liters per minute at 12 or 14 breaths per minute. Tidal volume is 500 cc's, and then you get them ventilating back on their own. You should kind of take a look at their minute ventilation, and it should be somewhat close to what you were needing to control their CO2 with the ventilator. So that's another parameter that I look at if I'm like, man, should I really extubate this person or not? I'll look at their minute ventilation, and if their minute ventilation somewhat matches the minute ventilation that was required when the ventilator was doing all the work, then I'm like, okay, I think I feel pretty good about pulling the ET tube. Now, if it was a extremely difficult intubation, I am a lot more cautious of pulling the ET tube versus if it was a very super easy intubation, super easy mask ventilation, then I'm like, okay, like I can. This is a if I extubate them and they don't ventilate, or I can deal with that problem versus somebody where I like struggle to get the ET tube in. I'm a lot more conservative of removing that tube too early.
Yeah, I mean, it makes sense. If you worked really hard to get it in, you don't want to give it up
Yeah.
quickly.
Yeah,
You
they're
know,
usually doing jumping jacks and reciting the alphabet around the tube before I pull it out.
you know. So when I've done some of the anesthesia, I always keep my sedation and my analgesic separate.
Mm-hmm.
Is there? I know you mix. You got your ketamine and Versed in the same bag, and maybe you add fentanyl to that, just like the war surgery.
I I stick it's the ketamine and Versed in a bag, and then I'll use bumps of fentanyl as needed. So I try to keep at least one thing constant, right? So if I reach a drip rate on my Tiva and it's whatever it is, it's 30 mils an hour, um, and there's a stimulating portion of the case that's coming up, or the patient gets stimulated, rather than trying to like increase my amount of ketamine and Versed I give, then I'll use fentanyl for that.
Yep, for
So that
breakthrough type
yeah,
stuff.
just for those, and then that's just kind of how I do it. I'm sure some people when they do their TIVAs, they'll put their narcotic in with their adjuncts. I usually keep them separate. Down in the field, I do. Sometimes at the hospital, I'll mix my fentanyl, like a low dose fentanyl, with my propofol.
So like I said, I'm trying to get end of the case, I'm trying to get them off the vent, get them breathing on their own kind of thing. I'll turn off my sedation altogether, keep my analgesic going as long as their, respiratory rates in a good range. I let that end tidal climb. Pretty soon you start seeing on the waveforms, both on the vent and also on the EMA, you'll start seeing these little notches start getting taken out of that waveform. I think, was it the curare cleft kind of things?
Well,
and that kind of alerts me.
Yeah, I mean, those typically those curare clefts, like the curare is the old neuromuscular blockers, right? So when you see those curare clefts, you're like, if I'm using a neuromuscular blocker, that just kind of tells me that the neuromuscular blocker hasn't worn off yet, and they can still have their own intrinsic respiratory rate, or intrinsic respiratory drive, but they're still their diaphragm is still weak, so they're unable to obtain an adequate tidal volume. So that's where you need to use like pressure support on your ventilator. So you can still have them ventilating on their own while they're still weak. You just need some pressure support so they get adequate tidal volumes. And then eventually you're going to come off of that pressure support. Like we usually reverse patients, whether it's with neostigmine and glycopyrrolate or another drug, Sugamidex. So, and then once we know that they're reversed, you should be able to back off and have minimal ventilatory support. Maybe you just have them on a pressure support of maybe 10 centimeters of water with a PEEP of 5. So you're just preventing atelectasis. So, because like with that elderly lady, what I did was when I removed her from the ventilator, I know she was probably unfortunately getting atelectatic or getting some atelectasis. But that was just that I have a ventilator. I don't have a way to recharge this thing at the moment. So I ate the fact that I knew she was going to get some atelectasis because I wasn't providing any ventilatory support, just a little bit, just to keep those alveoli open at expiration. So, but so like, and it's the same thing in the OR. Like I just shut the ventilator off. I put them on maybe a CPAP of 5, and then they can go apneic for a minute or two, and then eventually their end-tidal CO2, or their PaCO2 is rising, and then eventually they reach the apneic threshold and they start triggering and ventilating.
Yeah. I mean, I don't really just turn it off. I'm a chicken, so I'll just keep turning down my volumes, or I'll slow my rate because I'm trying to let that CO2 build. I just pose because I don't actually know what I'm doing, but it seems like it works.
Yes, for every minute, I think my students will kill me if I don't remember the exact numbers, but the first minute that you go apneic for your patient, your PaCO2 will rise about 7 points. And then it's usually 3 to 4 points for every minute after that. So like I usually feel comfortable enough, like at the end of a case, like I'll let somebody go apneic for a minute or two. And if they don't start ventilating by then, I'm like, okay, let me turn the ventilator back on, kind of, because at that point you don't know where their end-tidal CO2 is because you're not ventilating them, right? So then, a couple breaths, I'm like, okay, their end-tidal CO2 is 45. I'll let the ventilator do some of the work for a little bit, pop open those alveoli back open, and then just turn the ventilator back off and just let that end-tidal come, or let the PaCO2 rise, and I'm just trying to hit the apneic threshold. So,
okay.
But usually
you
when
can
I'm
do the same thing with the BVM.
Yeah, you could. Yeah, like so. Really, what I did with the my goal always towards the end of the case is to get them back ventilating as soon as possible. Some cases, like the surgeon's like, I'm done, and then you can get them back ventilating. But for the most part, like for a fasciotomy, you could keep the patient ventilating on their own for the case. So, and then just control they're most likely going to have a faster respiratory rate because those fasciotomies are pretty stimulating. Just use a little bit of fentanyl to slow them down.
And then you said you wait till they've finished closing, or finished either the last time they're using their scalpel, I guess. That's when you're starting to.
Yeah, I mean, it's like you're kind of, we always say like your emergence plan should start with induction, right? Like you should already kind of have an idea of like how you're going to do this, and the whole time that you're doing this anesthetic, like you're just thinking like how I'm doing things to make sure that this patient wakes up smoothly and in a timely fashion. Like my emergence plan doesn't start like I'm like, oh, the surgeon's done. All right, now I got to think about how to wake this patient up. So I'm already from the start thinking of like, how am I going to do this? So for a fasciotomy, if the surgeon doesn't require like neuromuscular blockade, I'll use a shorter acting neuromuscular blocker to intubate. So in the hospital, it's going to be succinylcholine, and I'll put the tube in, and then I'll get them back ventilating on their own as soon as I can. And then I'm just using narcotic to keep their respiratory rate around 12 or 14. So that way, when the surgeon's done, the hardest part of waking somebody up from a general anesthetic is getting them back ventilating on their own. So if I've kept them ventilating on their own the whole case, and I've titrated narcotic to their respiratory rate, which also is keeping them comfortable, that is usually that's like, okay, the surgeon's done. Now it's just a matter of just turning off your anesthetic gas or whatever else you're using if you're doing a TIVA to emerge the patient.
Okay. And then essentially you're doing the same procedure as far as talking to them, getting some kind of confirmation of like their level of awareness. And once they're in a good spot, go ahead and tuck them in.
Yeah. I mean, it's like with that elderly lady that I took care of, like I could tell she was back. I mean, she was following commands, and she had her ET tube in place, and she was nodding her head yes and no. So she was back. It was just a matter of making sure that when I pulled the tube that she was going to go off into a land of 50 other patients, and really no one was going to pay attention to her for a while, just to make sure that she was going to be okay.
Well, thank you, Kevin.
Yeah, no problem.
Is there anything else that we need to talk about that you didn't, or we didn't?
I don't think so. But like as always, the best place to kind of figure out how to emerge a patient is just come hang out with us in the OR. and we'll you can see you'll probably see a smooth wake up, and you'll probably see a stormy wake up, and you'll see how we deal with both of those.
Well, again, hey, thank you, Kevin. I appreciate it.
All right, Dennis, you take it easy.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.